All right. So yes, thank you again, everyone, for joining us for our month of May Ask CASA session. So this month we are discussing problematic sexual behavior in children. And we have Dr. Sasha Svendsen and Mary Harris, who were actually introduced to me by Diane Laney, who has joined us for previous trainings from the FACES Clinic. So some of you will have are familiar with Diane. If you weren't attending the previous trainings, again, you can view those on our website. And Diane's been a great resource. She's one of the lead trauma coach at the FACES Clinic, where our children come through when they come into foster care. So she has introduced me to Dr. Sasha Svendsen and Mary, and they're joining us tonight. So I'll let you both introduce yourself, and we'll get started.
Awesome. Well, first of all, I just want to say good evening, friends, because this is a group of our peers and our colleagues. So it's always nice to meet you all, especially people who actually volunteer to sign up to do this work. So thank you first for all that you do. Second of all, if you don't know Diane, you absolutely should know her because she's fantastic. And third of all, I also want to introduce me, hi, we'll talk about me in a sec, but Mary Harris is also a stellar clinician, a mental health professional, and just a really kind of renowned resource and growing expert in this region for this topic. So she is kind of going to be the star of the show tonight, and I'll kind of, I don't know, be the MC, I guess you could say. But anyway, so my name is Dr. Svendsen. I am a child abuse pediatrician by training. So I subspecialize in the medical evaluation of children when there are concerns of abuse or neglect. And I have been with UMass now for about 5 years. I also do work in the foster care clinic as well. And really am excited about the work that we do here, not only at the foster care clinic, but for the child protection program. I serve as the medical director of that group. And we are a multidisciplinary group here at the hospital out of UMass. And we, again, do kind of these comprehensive medical evaluations and psychosocial assessments, not only to identify injuries, but also really to help support families and caregivers through this process, no matter where they find themselves on the spectrum of this process. And Mary and I have really kind of grown into this PSB role together as we've realized that these are really a subset of children within our community who seem to kind of, I hate to say it this way, but kind of fall through the cracks of not necessarily DCF involvement, not necessarily police involvement, not necessarily CAC, because we're a DA-based CAC. So we really felt that these kids still deserved the same access to resources and to information that all other kind of child victims do as well. So that's really what got Mary and I into this work. So I'm going to let Mary briefly introduce herself, and then we're going to hop right in because we are very excited to be here with you all tonight.
Yeah, sure. So my name is Mary Harris, and I am a clinical social worker and play therapist. And so I've been in the field now of child welfare for over 10 years. And kind of like what Dr. Svendsen was saying, this has just become a passion of ours and of mine. I feel like it's something that triggers a lot of people. And so we either kind of overreact or underreact. And so our goal is really to help people find that nice middle ground to see that, stay grounded in that these are kids that are having some issues and we need to help them, and that there's a lot of hope in that. And so that's kind of our goal, my goal for you guys today. And like Dr. Svendsen said too, just I'm so grateful to be here. And so thank you for the opportunity. So
awesome. So we're going to jump right in, and we don't have any disclosures to tell you about, although we did receive a small grant from the hospital to kind of really dive into this and do some more training and education on this work. So we have to thank the UMass Remlard Community Service Fund for that. And I really do just need to draw out my gratitude to the people kind of pictured here, but in particular, Diane is kind of our cheerleader and our connector of all things having to do with caregivers and foster care parents, and she is just really the queen bee of all of that. So we feel grateful to have her on our team. I also want to introduce you to another person who's with us today. I'm going to make you say hi.
Hello.
This is Lucy, and she is a newly third year medical student who has made the choice to work with us as well and dive into this. And she's bringing us into the technological era. So we have some fun interactive things we're going to be trialing on you this evening. And then, of course, Mary, who has already been introduced to, but just I feel really fortunate to work with such a wonderful team. All right, so a few disclaimers. You know, from the title of this presentation, we're going to be talking about problematic sexual behavior in children. No surprises there. So if you are in a place where you don't want other people to hear this or whatever, pop your earbuds in, but just kind of let you know that that's what we're going to be talking about. We also just want to acknowledge, I know this is the work that you guys have signed up and volunteered to do, but you know, certainly talking about abuse and neglect are not always easy, especially as it relates to the potential for sexual abuse. So we just need to kind of acknowledge that people will come at this with potentially their own experiences, their own experiences in working with children who have experienced this. So just if anything is kind of triggering, please do what you need to take care of yourself. We will not be offended. And finally, sorry, someone say something?
Yeah, Sasha, I was just wondering if I could interrupt for a quick second. And I just wanted to let people know, some people had messaged me that they don't really feel comfortable being on camera. And I told them that's completely fine. I love seeing people's faces personally, but we know this is challenging. And if it does make you feel more comfortable to be off camera, you know, that's fine. But we're really glad that you came here today to talk about this.
Thank you, Diane. I promise we will not be offended. And we are just so grateful that you are giving us your time this evening. And then the last piece, I do, you know, in the ideal world, we would all be together in person and sharing hopefully just some camaraderie and some laughter. But Mary and I are going to, at times, there may be little elements of some humor. It's not because we take this lightly at all, but we're just trying to kind of make this topic a little bit more palatable, emphasize some key points, and then really just kind of attempt to engage you over the next hour. So with that, we have this really cool thing that we're going to do. So if you all can take out your phones, and I believe you just go to your camera and you hold it over this hover over this QR code, and it's going to have a question pop up, and we're going to do a little bit of kind of polling as we go through tonight to hopefully make this a little bit more interactive. And you're going to hear me talking to Lucy because she's helping me run the show here. Do I hit get started? Yeah. This one? This one?
Yes.
Yeah. Okay. Sorry. Got it.
Yeah, you're good. And,
All right.
and Dr. Svendsen, this is Jamie. I'll be following along. If there's any issues with the technology or any trouble, I'll speak up. Otherwise, it means it's going smooth on my end. And if anyone
Beautiful.
has troubles, just
Beautiful. And similarly in the chat, I want this to be interactive. We have a whole host of slides, but if y'all want to go off on a different topic or a different kind of angle, Mary and I are happy to oblige. So I just want to make this work for you. So the first question that you're looking at is just how familiar are you with this topic? And it looks like most people are falling in the sort of, I have a pretty good idea. No one's saying that they should be giving this talk, so that's probably a good thing. And we have a few kind of maybe never heard of it, but again, so we have a pretty good array here. So that is great, just to get an idea of where people are at and kind of the audience that we're talking to. My next question for you all is, and keep the poll, excuse me, open, is what words come to mind when we say kind of the phrase problematic sexual behavior in children? Can be anything. So we have abuse, we have previous trauma, we have scary. I absolutely want to acknowledge that one. Anybody else? Sad, trauma.
There's a comment in the chat, inappropriate masturbation.
Problem. All right. So these are all great points. So, you know, we're going to try to touch on all of these, and hopefully by the end of this, I'm going to ask you the same question in about an hour. And I'm hoping that the word choice that we kind of fill in the blank with may be a little bit different. That's my hope. That's the goal for the next hour. So thank you for doing that. We're going to try to go through some cases. We're going to ask some questions. We're going to do this polling thing. And we're really going to use that as a way to kind of reflect on how we think about cases, the lens through which we see things, and kind of how do we think through problematic sexual behaviors, and then kind of really use that as a jumping off point. So tonight we have a lofty goal or challenge ahead of us, but we want to really kind of describe what's normal for sexual development in the context of kind of what we expect to see. We want to think about the characteristics that make certain sexual behaviors in children problematic. So what is it that defines or makes a behavior problematic? We want to consider the context. We're going to have a brief discussion about the context in which the behavior is occurring. And then we really want to focus on kind of the practical strategies, again, to make this less scary, less intimidating, less, you know, sad or emotional, and maybe just perhaps see it through a slightly different lens than we did before. So I want to acknowledge that sexual behaviors in children occur on this continuum. First of all, they're very common. It is a normal, expected part of development, just like walking, running, jumping, skipping. When we think about kind of gross motor skills, there are similar things that kids go through kind of on this continuum of what is expected as far as sexual development goes. And in fact, more than 50% of children kind of talk about engaging in some type of sexual behavior before the age of 13. So when we think of this continuum, we're going to think of kind of more typical expected on one end. On the other end is kind of problematic, perhaps even harmful or illegal. And then in the middle is kind of concerning. So what we're going to try to do tonight is use this traffic light analogy, all right? So we're going to talk about green being typical or developmentally expected behaviors. So that's green. Go however you want to think about that in your head, but kind of expected, typical, that's where we're at. Then red on the opposite end of the spectrum is going to be problematic, or we need to seek some professional help pretty fast here because something is pretty off. And then we have this yellow category, and that's going to be the caution or the, you know, the slow down and the of concern behaviors. And so as we go through some cases now, I want you to think about if you're, you know, we'll present you with this and we're going to ask you, is it a green light behavior? Is it a yellow light behavior? Or is it a red light behavior? So we got to also acknowledge addressing the discomfort. So at some point, it's challenging, but we kind of forget about sexual development as being a part of normal, healthy, overall complete development, just like, you know, all of the emotional development, just like the psychological development, you know, gross motor skills, fine motor skills, all of that. There's this kind of whole continuum of development that's happening. And actually sexual development is a part of that. And I think kids are hungry for information, and we're going to talk a little bit about kind of what happens when they don't have access to good information and when they get bad information from certain places. But we just have to address, yes, a lot of people are uncomfortable talking this, and I will even include my own colleagues in the medical field. And so we just need to get better about how do we hold space to have conversations about what's healthy from a sexual development perspective. And we're going to give you some insight into that tonight as well. All right, Just in case you need that QR code again, I'm going to ask you to bring it up because we're going to do a couple polling questions through cases. So let me open the next poll. Oh, sorry, got to stop the other one.
Yeah.
Thank you.
Mhm.
And now we're going to open the third one. Okay, another poll is active.
While Sasha's doing that, I just wanted to remind everybody that we don't see your, specific answers. Like it doesn't say Jill said this or, Jamie said that. We don't know. We are just, you're just a person responding to that survey anonymously. And I want you to just give your honest gut answer.
All right, so case number one, I'm going to read out loud to y'all. Foster mom walks into a room and sees her 6-year-old foster daughter kissing her 6-year-old foster brother on the cheek and kind of leaning into his body. She immediately separates the children and asks them what they were doing. And both children tell her that they're playing a game called Boyfriends and Girlfriends. So our question to you is, on that continuum, are we talking green light, typical, expected? Are we talking red light? There's a major problem here. We need help now. Or are we talking yellow light? We got to proceed with some caution and understand what's happening.
And we have green in the chat.
All right, so we have about 2/3 green and 1/3 yellow on the poll. So we're just going to keep that in mind. We're going to kind of discuss these again, but we're just going to go through them all first. So interesting. All right, let's go to the next case. Same thing. All right, so case 2. Dad comes home on his lunch break to find his 16-year-old son in bed with his 16-year-old male friend / neighbor. Both appear to be naked and embarrassed. Green light, yellow light, red light. This is so exciting. The polling's working.
I know, I really like this. This
In
is
the
great.
new age of technology here, people.
It would be awesome if we could see, because you can see the percentages, right? But we can't. So I like that you're
I did
sharing
this
them.
on purpose, Jamie.
Oh,
And
you-
I'll tell you why. But
Look
yep,
at you.
it's gonna be a learning curve type of thing. So
Yeah, no, you're
so
doing
we're
great.
seeing about a quarter saying green, about 60% saying yellow, and about 12% saying red. All right, move on to the next one. ... Does this change? Sorry, I gotta stop the poll. All right. Does this change at all if we have a 16-year-old male and a 16-year-old female instead of 2 16-year-old males? Does that change your green light, yellow light, red light? Interesting. It looks just about exactly the same. All right. And I have another ... for you. What about 2 16-year-old females? And here's the poll for that one. All right, so it changes a little bit.
And I
All
have
right.
to say, I like that, because we can see you guys kind of shifting them around too, and I like that because this is not meant to be easy. We wrote these to really get you guys thinking, and these are all off of cases that we've gotten calls on, and so people are wrestling with this, and so I love kind of seeing the red go shoot up and then go down, and then I think that is part of this process, and so I wanted to encourage you all in that. I really like that you're wrestling with it because it's hard.
All right. Case number 3. I'm opening the poll now. A 7-year-old female discloses to her teacher that her 15-year-old male babysitter has been having sex with her for the past 2 years when he watches her. She reports feeling afraid because he lets her come over and play with his puppy, but he told her if she tells anyone, he'll kill the dog and she will never see it again. We are in the 100% red zone for that one.
I was hoping so. I didn't want to say anything.
Universal agreement,
but I was pretty sure. Yeah.
All
We
right.
got red, it says in the chat.
Y'all are doing fantastic. All right. Stay with us here. All right. So now we're going to go to case number 4. We're going to talk about a group of 8 and 9-year-old girls are at a sleepover and they're playing online, and lo and behold, they find their way into an online chat room. They begin talking with men who tell the girls that they will give them tokens for their video game if the girls take videos and pictures of themselves naked. Red, yellow, or green? Got mostly reds and some yellows. All right. We're moving right along here. Y'all are doing fantastic. Now we'll go to case number 5. A 12-year-old child on the autism spectrum has begun masturbating in class. So this was one of the that as to why this behavior is happening. The teacher said she tells him to stop, but he just does it again a few minutes later. Red, yellow, green. All right, we are about 3/4 yellow and about 1/4 red.
These are hard. They really make you think, and they make you think about your own biases and your own like beliefs that you didn't even realize. It's interesting.
Absolutely. And I will say you have Mary and Diane to thank for that.
Yeah, it was very well put together. Thank you.
All right, we have just one more case. So this is our last one. And this is a 10-year-old girl has been asking to kiss her 10-year-old stepbrother's penis. Mom overhears the girl asking her brother, and the brother responds with, "Only if I can touch your breasts." And there's a lot of movement, which I love, because this is where the learning happens. So we have kind of a couple for green. We have about maybe 35% for yellow and about 50% for red. All right. Y'all did fantastic. Thank you for doing that. And now we are going to kind of break down the cases, pull them apart a little bit, discuss them, and that's really going to kind of launch our discussion for understanding what we're talking about. So Mary is going to debrief kind of some of this discussion for us.
Yeah, so when we talk about cases, when we get calls on cases, we think about them kind of in this way. So there are some within red, yellow, and green, right? The big overarching, there may be some flags, right? That will tell you, hey, this might make it a little more okay, this might make it a little more concerning. And so this is kind of how we break these down. So in this first scenario with the 2 6-year-olds playing boyfriend and girlfriend, the things you want to look out for are the fact that we have a 6-year-old and a 6-year-old together, right? So when you think about typical sexual behavior and then more concerning, typical is same age peers. Those are actually, and kind of kids who live in the same home. Those are a little more normal, typical behaviors because those are the kids that they're around and they developmentally are at the same stage. So 6 and 6 is kind of a, hey, that's more, we would expect to see some of that. We also, I highlighted there where it says both children. So there's an agreement here, right? This agreement that both kids agreed to play this game. And so when we think about kind of in typical interactions, that's great, right? There's no forcing, there's no, you have to do this. They both want to do that. And then the idea of boyfriends and girlfriends. So you think about 6-year-olds and that's kind of what they're seeing, right? Is, hey, what do the kids on TV do? What do maybe my older siblings or my mom and dad or other people? So they're kind of role playing out the relationships they see. So this case was a green for us. This would be a pretty typical behavior. It's still, again, not that you don't want to do anything about it, and we'll talk about that, but we put this in the green zone. So if you guys voted green, great job. If not, that's okay. You want to be thinking through what made you more concerned about this? And we'll be talking about some of that too, okay? So there's no real wrong answer, I guess.
Yeah, and I just wanted to let the audience know that that is based on a real case that we had here, where we had some DCF workers and foster parents that were very, concerned, and they called and they were happy to hear that it was green.
And if I recall correctly,
Absolutely.
because we were able to kind of reassure them that this is kind of what we see. All right, case numero dos.
So number 2, you're gonna go back one.
I'm sorry.
So number 2, this too is, we put this in the green zone actually. So 16 and 16 are, again, same age or similarly aged peers. And the other piece that we took from this is that they felt embarrassed about that, right? Which is a pretty typical reaction, right? If you have somebody walking in on you, hey, you're gonna probably feel pretty embarrassed that things are going on. And we also kind of noted in the state of Massachusetts, right, 16 is the age of consent, which is an important piece to remember too. A lot of kind of, it's not an atypical time to begin exploring and doing some of that. And so that was a big piece. And that embarrassed is very different than kids who feel ashamed, afraid, right? Those are some other feelings that you might want to look at, but embarrassed is not that odd, right? So we had this one as a green. And that you guys had actually put that as primarily yellow. There was a little bit of just, right, a little green, a little red, but mostly yellow. And it is, we did that on purpose too. And I love what you said, Jamie, earlier about bias, right? And our own kind of, what are we taught? What do we believe? And so sometimes that's why we added those additional questions of, how would this change for you if it was a boy and a girl or a girl and a girl? Because I think it's really important that we think those things through, right? What are my values? But then maybe somebody else might feel differently about that, and kids might feel differently about that, right? And that showed in some of your reactions too. They typically were kind of more yellow again for pretty much all of them. The last one, interestingly, the 2 females had the highest green, which I think is notable, right? Which again, I think is part of some of our societal stuff and worth just reflecting on and thinking, which is 2, I want to come back to. We do these cases as a team for that very reason, right? So that I can say, hey, this is bringing something up in me. Sasha, what do you think? Diane, what do you think? Because then we can help each other to say, yeah, maybe that's just you. That I don't know that that's actually an issue. And so it's really important, I think, to talk about it together. So.
All right, case number 3.
All right, number 3. So this one, you guys were dead on. This is a red. So key factors here, big age gap. That also the fact that the 15-year-old is in a caregiving role, that is very important. So there's some power dynamic within that. That feeling of being afraid, right? That she's kind of feeling like he's saying something bad is going to happen if I don't do this. And you always want to be afraid or kind of have your guard up a little bit, your lights flashing when people say, he told me not to tell, or I was told something would happen if I tell. That again is kind of a sign of a more problematic behavior, because it again kind of goes into this idea of secrets, shame, power, that kind of thing. So this was, you guys were dead on.
All right, number 4.
Number 4. So this one was tricky, and I want to preface that. So we marked this as yellow. You had a couple people had yellow in here, but mostly red. And I don't think you would be wrong in making that decision. We want to help you guys see where some of this lies. So 8 and 9-year-olds together, that's pretty typical, right? And going online, typical, right? Finding their way into a chat room, and kind of that there are men here, so that makes this problematic. But part of the question becomes whose behavior within this is problematic, right? So the girls going into a chat room and being told, hey, you can have something that you want if you give us this night, if you give us what we want, is problematic, but some of that falls on the adults, right? That is very different than that falling on the girls. And so we want to be clear about that. So when you're dealing with this, it may not be that the 8 and 9-year-olds need a whole lot of problematic sexual behavior treatment, right? They may need some help around safety awareness and things like that. But that's kind of typical for that age and for needing online safety. So that's not a super abnormal thing. It requires a lot of support and education is kind of what we would say.
I have a question about that one, Mary.
Yeah.
Would your approach, and I'm sure that the answer is not super simple, but would your approach shift depending on what the 8 and 9-year-old girl's response was, right? If they sent the pictures or not. So then does that become problematic? And again, I know that's a broad question, but what do you think?
Absolutely. Yeah, it does change. So one of the things we'll talk about is how often is this happening? So kids where something is more problematic, we think of kids doing it repeatedly, right? So
Right.
if you say it within that group, there is one of those girls who said, hey, I know this website, let's go to this website because I've gotten on there before and I've gotten some pretty cool stuff. And if you don't want to do this with me, then I'm not your friend, right? That's a whole nother ball game than saying they found their way in here that, and again, somebody's kind of dangling something out there for them that feels really good to them. And so we'll talk a little bit about that, but yeah, there are definitely factors that could change that rating. Does that answer that question, Jamie?
Yeah, I think that makes me think that even if their reaction was to send the pictures, that doesn't necessarily mean they're having problematic sexual behavior, that you can go back to the education piece on internet safety and
And
safety.
actually, Jamie, that actually falls potentially in the realm of also then child sexual abuse if it's adult men who are
Yes.
seeking out these young girls. And they're kind of, again, more in a role of kind of being victimized than
Right. So that the treatment shifts and the focus shifts.
the focus, the lens totally shifts. Exactly.
Okay, thank you.
Of course, great question.
So this one is the 12-year-old on the spectrum masturbating in class. So this is a yellow, and most of you put yellow, a few, but there was a pretty good number that said red too, and we can see why, right? And that's an important piece too. Some of this is how do the other kids feel about what's going on? So we have kind of the displayer of problematic behavior, what's their experience, but say there's another kid who is really kind of harmed by this, that may change stuff, right? And so we want to keep that in mind. But we did put this as yellow because of a couple of different reasons. So one is the age, 12, not an atypical time, right? To be kind of exploring your body, feeling like excited about certain things, noticing touch, that kind of stuff. And then if you put into the factor some of, if a child is on the spectrum, potentially they have some lower social awareness, some difficulty understanding, social roles, and also kind of some kids we have that have a really hard time with kind of, oh my gosh, I just lost the word, that it has to keep happening. That's kind of a repetitive behavior that they are struggling, a compulsive behavior. So that's another piece that I think you want to be mindful of. And so we put that in there about kind of they're perplexed why it's happening. She's telling him to stop, but he just keeps doing it. So there's clearly a problem, right? He's continuing to do it, even if the adults are trying to tell him to stop. But at the same time, you want to be mindful of the context, his context, and helping to figure out how do we manage this with knowing kind of where he's at developmentally and physically. Does that make sense?
Yeah, I think too, the red responses, and I could be wrong, and it's certainly not a judgment on the responses, but is whether or not there was exposure. Like, did the children see his penis, or is he doing this through his clothing? So I think that brings it to a different level for the other children in the class. But yeah, thank you.
Yeah. So the last one,
I realized that I totally goofed it because I changed the ages on you all.
which is okay.
So
And you changed the word there instead of breast.
I did. I was really trying to get y'all. Can't get one over on anybody.
Nope.
Okay, they're both yellow. I will say we put them both as yellow. So that we'll go. I'll start the initial one if you want, and then you want to explain the
Yeah.
more complicated
Yeah.
one. So the initial one where it said 10 and 10, and kind of asking to kiss and touching. So we put that as yellow because again, they're kind of similar ages and potentially that it's some exploratory stuff, right? And so there's not necessarily a disagreement about what's happening. There's not some like negative feelings about it, but clearly some intervention needs to happen. And so I think the key piece in this one is, is this the first time that this has happened, or is this like happening all the time, right? So the way we wrote it was that this is something that mom just kind of overheard one day. It's not an ongoing thing, which makes it a little more on the yellow side, and that they hadn't actually done it at that point, right? That it was asking to do it, talking about maybe they would do it, but it hadn't actually happened at that point. So that's why we marked it as a yellow.
And then Sasha comes along and she screws it up because she's going to tell you all that she's going to try to make it complicated. So when we change the ages a little bit, if we think about a 7 and 11-year-olds, now you're saying, okay, but you told me if there's an age difference, then we have a problem. But I would suggest to you that's where we have to kind of do a little bit more thinking and have a little bit more curiosity. So perhaps the 7-year-olds, right? Not great boundaries in general, and kind of that, what's allowed, what's not, starting to really kind of understand and internalize that. Whereas perhaps maybe the 11-year-olds, maybe the like physical boundaries are a little bit better, but now we add in that sense of impulsivity, right? And like, well, yeah, if you're saying it, let's, as long as I get something out, like, so I think there's different ways to look at this and certainly different lenses, but that's where we just, as we manipulate these different factors, how does it change on that continuum for you all? And that's the process that we wanted to practice. And now we're going to kind of talk through some more of the details of that. All right. So y'all did a fantastic job, let me just say, and thank you for engaging with us in that way. And now we're going to kind of do some of the more didactic teaching part of it.
Excuse me, Dr. Svendsen, we have a question in the chat. Is PSB a diagnosis? What percentage of kids in foster care exhibit the behavior?
So we are going to talk about this, but PSB is actually not a ICD-10 code. There's no diagnostic code in either mental health or in the medical profession. So it is coded as a behavior concern. And so as far as, but I think the logistics of that versus what we know it is, so it's that whole ball of wax. And something, regardless of what you want to call it, needs to be done. And there's different types of things that need to be done. And that's what we're going to really spend the rest of the time talking about. I don't have great numbers for you. So we're going to talk about at least half of kids say that they engage in some kind of sexual behavior before they're 13. So that includes things that are expected and things that are totally not expected. We're going to talk a little bit more about prevalence when it comes to thinking about what falls really under the umbrella of sexual abuse that actually makes it to a children's advocacy center and some of those numbers, and I'll extrapolate out for you. But again, I think it all depends on how you're defining it, and we're going to talk about that. So getting back to kind of, again, what's normal, what's developed, I don't like normal, but what's developmentally expected? What is typical? What do we expect to see? Play that's happening between kids who are around the same age who already play together. It's not some random kid that they just met at the park, but it's kids who are already, friends, cousins, things like that, already kind of playing together. It's fairly common. It's that spontaneity, that voluntarily or mutually agreed upon. If it's discovered by parents, it kind of gets diverted and stops. It doesn't tend to persist after people kind of attention is brought to it. It's either seen as something positive or neutral. So, hey, we're exploring, we're trying to kind of make sense of either what we're seeing or what we're experiencing or what we're exposed to. And again, it's not related to a child's sexual orientation. So just because two boys might be kissing doesn't speak to that's going to be their preference kind of moving forward. But it's really kind of, again, geared at a much younger kind of psychological and emotional state that's more about exploring the world around me, trying to make sense of things that I'm seeing that perhaps my brain doesn't understand, and really kind of thinking about seeking pleasure, avoiding pain, and just really learning things by trying them. Contrast that now, though, to what we're calling problematic sexual behavior, right? And as Mary kind of was pointing out, in those cases that were yellow and red, what were some of those factors? Remember, it was the frequency of the behavior. Is it to the point where this kid is just masturbating all the time, that he refuses to go outside and play with his friends? Is it impeding on his ability to kind of interact socially with his world? You know, certainly developmental factors. Is there a big disparity either chronologically or developmentally in age? And Mary alluded to this, but what is the level of harm to the children or to the child who's kind of the recipient of that behavior? And that may vary situation to situation and case to case based on a number of factors that we're gonna acknowledge here. But this is a nice little graphic. We have some great websites and things that you guys can utilize, but this is a nice little just snapshot of kind of, again, this continuum. But you know, again, typical, that green side is more the exploratory, we agree upon it, same age, and it kind of happens periodically. Whereas that where it gets to be problematic, is it planned? Are we putting a lot of energy and focus into making sure that we have time for this to happen? Is there any coercion involved? Are there different ages, whether it's chronological or developmental? And then again, is it a preoccupying factor where I am just so focused on this that I can't participate in other things, or I'm not easily distracted by other fun things that would be expected? I think it's important to acknowledge, though, as we've kind of talked about, is that person, that child who's receiving the behavior or engaging in it in that way, can have varied responses, right? So whereas some children might kind of not think anything of it or have any reaction, others might have more externalizing symptoms. You know, some of those behavior problems, aggression. Some might have more of those internalizing symptoms of, you know, nightmares, kind of startle response. It can affect people in different ways. And that's another thing to consider as we're assessing where on the kind of continuum this falls. So when we think about the risk factors that contribute to PSB, we think about it as peeling the layers back of the onion. And that's where we as the adults in these situations have to get curious, and we have to be willing to kind of ask some questions and face some of that discomfort that I think we all have talking about this topic in general. But we're going to talk about some different factors. And we can really kind of break them down into, are there vulnerabilities within the individual child themselves? Those are going to include things like developmental delays, impulse issues, you know, maybe language delays, kind of, but things intrinsic to the child that may inhibit their ability to kind of really respect the boundaries or understand some of the boundaries and social cues. Then we have family adversities. We have to kind of think of that as its own chunk, but those are going to be things that relate to a caregiver perhaps not being as present or available to a child to help teach them about kind of what is expected, privacy rules, kind of body safety, but also kind of lack of providing accurate information, because we all know if kids don't get the information from us, where are they gonna go? Please unmute yourselves and say it out loud.
Friends and the internet.
They're gonna go to friends and they're gonna go to the internet, exactly. And where particularly on the internet are they inevitably gonna go? To pornography. And we know that pornography is by no means an accurate representation of healthy sexual relationships and interactions, but that is what gets modeled. And so that's where we as grown-ups and adults in these situations have to be willing to kind of help kids learn, navigate, understand, and provide them with the age-appropriate information. There are some really great books and resources that we will also kind of point you in the direction towards, but to help with some of these conversations, but they are critical to have. And also don't forget about your pediatricians. That's what they're there for, primary care providers, to help navigate some of these conversations and discussions.
Excuse me, Dr. Svendsen. If you send any resources to me, I'll keep a folder in my desk, problematic sexual behavior resources, and then any of our volunteers can email me. And if I'm stuck, we can reach out to you again, but just so all our volunteers know, I'll keep that in mind.
Thank you so much. That's wonderful. The two other kind of big picture items that we want to talk about is one of modeling of coercion. So is there in this child's environment or the context of their experience, is there violence? Is there in particular physical violence, perhaps witnessing domestic violence or interpersonal violence, violence amongst peers, and even in their community, because that certainly speaks to, you know, how I see the world and how I interact within the world, if that's what's modeled for me. And then the last piece is kind of this modeling of sexuality, which becomes important, especially as we think about individual families or contexts of caregivers. What is discussed? Are people walking around the house naked? Are people bathing together? Are people in the same room as adults who are engaging in sexual activity because there's only one room in the house and we all sleep in the same room? So I think, again, understanding that each of these pieces is part of putting together understanding for this particular child, the context that they are experiencing the world in, and therefore, how does that impact the framework with which we see the behavior that they are expressing?
Dr. Svendsen, and not the slide you were just on, the previous one when you talked about physical, one more, nightmares, heightened startle response or avoidance triggers. Is this, and we had a question that goes along with this in the chat, is bedwetting or, incontinence suddenly becoming like defecating or urinating? Are those signs that are common? Okay.
Those can be other common signs that are expressing that something is going on for the child in their environment, right? It doesn't mean sexual abuse. It doesn't mean problematic sexual behavior, but it means that something is impacting them in a way that is now affecting exactly.
Yeah, so something stressful, something has shifted. Thank you.
Great questions. Thank you for asking them. Now, when we first asked the question, one of the words that popped up for people was sexual abuse, right? So if they see problematic sexual behavior in children, it is a very common myth, even in the medical community and the medical field, to say that if a child is exhibiting problematic sexual behavior, that means that they must have been sexually abused. I just want to make it clear that is not the case. And furthermore, the majority of kids who actually experience sexual abuse don't go on to exhibit problematic sexual behaviors. So while it's important to think about as a possibility, as a reason for why we might be seeing problematic sexual behavior, the thing that we see more commonly is exposure to physical abuse and domestic violence as actually being kind of a precursor for this problematic sexual behavior. And again, thinking of it less about through our adult lens of sexual gratification, and kids don't think about it that way. It's much more of a externalizing kind of spontaneous thing that they are doing to express something that doesn't make sense in their world. And so again, we're just kind of shifting the lens through which we see that. I do need to just make a little point that once we talk about adolescence, so once we talk about kids who are 12, 13, 14 and above, it gets a little bit trickier. And again, in the state of Massachusetts and wherever, if you go to different states, but laws around this start to change and start to be impacted. So what is considered problematic in an 8-year-old, a 9-year-old, a 10-year-old may actually start to be considered illegal in a 12, 13, 14-year-old. So that's another kind of aspect of adding to the confusion of all of this is kind of, we have some more varied characteristics that enter into adolescence where we start having to think about sexual gratification, attraction, is substance use a part of this? And then really thinking a lot more about exposure to sexual content and what is perhaps being viewed and then acted upon. And because again, they think that, well, that's what I saw in the porn, so that's therefore what sex is. And things start to get very muddled. But I need to make that point that when we start to reach adolescence, the red light, yellow light, green light becomes a much more difficult exercise to do because we have lots of other factors at play. So Jamie, you had asked a little bit about the numbers, and I want to come back to this and really highlight that however you want to look at this, but of all of the cases that are referred to children's advocacy centers regarding child sexual abuse, about a quarter of them involve a child acting out against another child. So when we think about the actual numbers and we kind of apply that, we're talking about somewhere between 75 and 95,000 kids nationally a year. Those are kids that CACs know about. So those don't include all the green kids and a lot of the yellow kids, right? So those are a lot of mostly the red kids. So I think this is a lot more common than people think, but we have a really difficult time getting accurate numbers or estimates because we just don't collect the data in a way that is helpful or useful. All right, I want you guys to do me a favor, and whether you want to close your eyes or however you want to do this, but I'm going to ask you to picture a child in your life, whether it's your own, whether it's a child that you work with, but a child that you care about, that you know that you are very kind of bonded to, the child is attached to you, that child. And I want you to think about what your gut response would be if I were to call you and tell you that that same child was engaged in kind of harming another child in a sexual manner. And if we think about it that way, I think it really personalizes it to help us understand that there is a lot of fear, there is a lot of anxiety, there is a lot of shame and stigma that goes along with kind of these situations, not only for the children themselves, but for the caregivers and the adults who love them, care for them, and are there to help and protect them. And I think that I'm so appreciative for you all for even being willing to take the time, you're an hour and a half out of your night to come talk about this, because it just shows that you're willing to see things a little bit differently, to learn, and to really be invested in how do we get past the shame as the barrier that stops this conversation from happening. How do we move through that and actually have a healthy dialogue and kind of formulate a plan moving forward? And that's kind of what we're going to focus on. With shame, language becomes really, really, really important. And I'm sure you probably have heard of these children who are exhibiting these problematic sexual behaviors being labeled as perpetrators, being labeled as sexual offenders, being labeled on, even put on kind of the juvenile sex offender registry lists for the state. And that actually really does a huge disservice, because we want to remember that first and foremost, these are kids. So those labels are actually not helpful. And we've seen that those labels actually have huge impacts on how these cases are are dealt with from a professional standpoint within the community, and the professionals who are charged with kind of helping to keep kids safe. So we like to, again, not use that kind of inflammatory, stigmatized language, and talk about the child with the problematic sexual behavior. See how that's very, very different? And that's, again, because children aren't little adults. These are still kids. So therefore, we want to use that child first language, that child friendly language that acknowledges that this is a kid. And as Mary was saying at the beginning, something is off, something is wrong. It is definitely something that is serious and needs to be tweaked, but this is not a life sentence that means they are going to go on and be, you know, sexual deviants or have really significant sexual issues as adults. So the right words: children with PSB, again, exhibits a behavior problem, not an offender. They're sick, they're a predator, anything like that. Kids, for no matter what reason, right? None of us want to be, none of us want to be defined by our behavior that we exhibited when we were younger. So again, thinking about that when we talk about these children, and the language that we use and that they hear us use is really important.
And Sasha, I wanted to say here too about that language piece that many of you, you know, as CASA volunteers, you're going to hear the wrong words all the time. And so, you know, I'm not trying to make you the language police, but I think that if you just can even role model the appropriate terms or, you know, for these folks, because I think the legal system can be particularly problematic in their use of terms.
And I love that you said that, Diane, because I think one model that I had one time, it was really helpful, was, you know, people were talking about that and they were talking about, well, the perpetrator, and this woman, she was so good. She was like, wait, hold on, what did you say? And they said, well, the perpetrator. And she goes, oh, you mean the child with the problematic sexualized behavior, right? Mm-hmm. And so sometimes it is just that simple of a way to just help them redirect, to come back to that at the heart of this is a kid. So it's something that I think it is really hard to get out of the habit of doing that, especially in the legal system. But it's so important to making sure that these kids are protected and kind of just really seen in the way that they are. And so I love that you said that, Diane, because I think that's really important. So.
Yeah, I'd like to add too, I think I could see within the legal system that these negative, you know, labels and terms are used because they easily shift you to place blame and like it's easy to be negative. But then within, you know, when you think of just the general population using these terms, I think some of those negative terms probably must come from fear, right? Fear that that child is going to hurt my child or somebody else. And so it's natural to shift like and use those terms as like a protective mechanism. But I think I really like what you're saying is, and to shift to help that child and to help them, you know, hopefully heal and grow and yeah, thank you. I think you bring up very good points.
Yeah, because what do we do with perpetrators, right? But I think when you think about it from a legal perspective, you lock them up, right? That's kind of the mindset. And that is a big thing that I think people don't always think about too, is, are you going to lock up a 12-year-old? Are you going to lock up a 13-year-old? Are you going to, like, how does that work? What does justice really look like in this situation? So that's the other piece, right? Is like, so when we say perpetrator, what usually comes from that is we want them to go away. But the reality is that is not what's going to happen, right? Especially when things are within families, they are going to remain a family. And so how do we keep that family centered? So that, I think it's really, really important. So yeah.
It's like I planted you all, because now this is the perfect segue. All right. So we're going to spend our last chunk of time talking about this from there's hope, right? This isn't a life sentence. This doesn't mean that this child is going to go on to have these horrific problems as an adult, or who needs to be locked away and not be part of society or be part of their community or be part of their family, for Pete's sakes, right? They need to still be very much a part of something, and just have a lot more kind of structure and reinforcement around safety, supervision, and kind of support. So that's what we're going to jump ahead to. You guys have seen things like this, but this is where protective factors are important. I'm not going to harp on this, but this is where we can do something. This is where we can help the caregivers to do something. And Mary's going to really spend some time talking about that. I do want to acknowledge that there is evidence-based treatment, just like when we think of trauma-focused CBT as an evidence-based therapy for trauma. There is an evidence-based therapy for problematic sexual behavior, and people, children and families who engage in that actually have a very, 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 like less than 3% very low rate of recidivism. So they do not go on to continue to have these behavior problems. So there are effective means of kind of addressing this. We are not going to focus on that evidence-based treatment because that's a whole nother talk. What we're going to focus on now is what we would like caregivers, DCF workers, CASA workers, kind of people in the immediate setting, once this behavior is recognized or identified, what we would like you to do while we are waiting in that process to get this child into services. So we have what you can do in the moment, what you can do responding, and what you can do moving forward. And this is where Mary is going to really kind of focus our discussion.
Yes, so the first thing when you become aware of an incident of problematic sexual behaviors is to breathe. So breathe, breathe, breathe. You need to be okay to deal with this thing going on. So the very first step is to stay calm. That is the most important thing. And know that if you don't stay calm, that's okay. You are a human being. That's part of kind of the process too, to be able to get yourself to be okay enough to help stop the behavior. If it's still happening, you're going to stop that behavior and get curious about that. And I think that's a hard space to be, but that really requires being able to ask those questions that we talked about in those cases of, tell me what happened. What were you thinking during that? Where did you get the idea to do that, right? You're really exploring to figure out, is this a green red flag, a yellow, a red, how concerned do I need to be? So when you get that information, then you're still going to be very clear about what boundary was crossed, right? So kind of, if we go back to that first case of the two kids that were kissing each other, you know, in this house, people don't kiss each other. Kids don't kiss other kids. That's not something we do. And so that's something we can't do it moving forward. And so then you're moving into then a plan moving forward. So those are the kind of 5 steps of staying calm, stopping, getting more information, getting curious, being clear, and then making a plan moving forward.
And I just need to say, I know kind of when we talked about it, green doesn't mean don't do anything, right? Green is still an opportunity for education, for kind of reinforcing what are the kind of the rules in the house or body safety or boundaries or things like that. It's an opportunity to discuss, and we have to take those opportunities when we're provided with them.
Yeah, so in terms of trying to stay calm, the goal is really to avoid shame and blame. What do we know when kids get kind of caught in something, right? They get kind of terrified, right? And their go-to is, there is something wrong with me. And that is the message you do not want to give to kids. And so you really want to be able to, again, be curious about it, be clear about what's going on, but at the heart of it, so the behavior is not okay, but you, yourself, child, are a wonderful human being who I love and who I'm going to help make sure that we get where we need to be. And again, if you mess up, that is okay. You then have the opportunity to teach repair, right? To say, you know, I was really scared. I lost it back there. I know that. I'm sorry. This is scary for me too. And so we're going to get through this together. Again, just because people mess up doesn't mean a whole lot of anything. That actually can be really helpful. So obviously stopping behavior is really important. Sometimes that will happen. A lot of PSB, you notice people find out about it because they walk into it. So you're gonna make sure. Other times it might not be. So stopping it could even be, so do we have two siblings who are sharing a room? So maybe you didn't walk into it, but hey, for right now, we're gonna keep these kids in separate bedrooms while we figure this out. So it's about stopping the ability to continue that behavior. So again, get curious, not furious is what we talk about. So help me understand. You want to ask open-ended questions. So not, who taught you that? What did you do? Right? It's how did you get that idea? How did you decide to do that? How did that make you feel doing that? Right? It goes back to some of those questions before that we talked about of, is there anger, shame? Is there, oh, well, I was just kind of wondering what, those are important things to find out. And then again, being clear about what happened, what went wrong, because they don't necessarily know. And so that's going to be an important piece and a way that you can help them in the future to come back to. So remember, we talked about people don't kiss each other in this house. So it allows you to also have a coming back to point to help remind the child on, which is really important. And then promoting safety. So that means for the child and for yourself and for other people potentially in this kind of family's life. So that can be teachers, other students, what you were talking about, Jamie, with the other peers. Did they notice anything? So you're looking at physical safety for everyone and psychological safety, right? And so those are going to be really important. And then body safety talk. So when we do talks with kids about touch and boundaries, what used to be used was good touch, bad touch. But what we found and what research shows is that that's not very helpful. Actually, it's confusing because bad touch can feel really good. And so that's confusing. And if you have somebody who you love who's doing something to you, that's confusing. So we've changed it to safe touch and unsafe touch. It allows there to be a little more clarity and for the adults to really be clear, this is what unsafe touch is. And so if this has happened to you or is happening to you, we want you to say something about it. It just helps take some of the gray out of it for some of these kids. We have this resource that we can share with you too, Jamie, for everybody. This is something we give to almost all the families that we use. We talk about putting it on your fridge, in the bathroom, just somewhere where kids can see it to say, my body is mine. Who are my safe people that I can talk to? So just as a good reminder and visual for families that we use a lot.
I like that. Thank you.
Yeah. And then the last part is making a plan. So I think that's one other piece that happens a lot with these kids is they fall out, right? So people get really afraid and then they're like, well, it hasn't happened in a week, so maybe it's okay. And then nothing happens from there. But what we talked about with the treatment is that treatment is important, right? Moving forward, making sure it doesn't get brushed under the rug is hugely important to make sure it doesn't keep happening. So you really want to make sure that the whole team is on the same page. So the school has some awareness of what's going on if that's needed. The primary care doctor has some awareness. Therapists know. Everybody's on the same page. So there's a clear, consistent message to that child about what's okay, what's not okay. And always considering safety and supervision. I talk a lot with families about protecting that child from themselves, right? So you're really making sure, how do we make this kid feel really contained in a way that feels safe, but is also kind of knowing that maybe they're not going to be very good at supervising themselves because they're a kid. So that's going to come from the adults.
One issue that came up for us recently was a parent saying, how much do I have to disclose to the school? Mm-hmm. And I think especially when stuff's happening at home, that's a really important question because, certainly different people have different responses to this. And I think, if we're not talking about kind of red behavior where we really need kind of everyone to know, be very clear about what's going on because there's really a problem and we need some professional help and involvement. I think that it is it's something that you kind of have to kind of feel out, but I certainly think there are situations where it's totally okay, and even actually in the best interest of the child, perhaps not to share every little detail about what's going on, but maybe pulling the teacher aside, especially for a younger child in elementary school, and saying, we're really working on this at home, and it would be really helpful to us if you could help to reinforce this for, Sarah, and you could help us reinforce kind of her body safety, her privacy, and some of those boundaries, because we're working on that at home, and it would be really helpful if we could reinforce that in school. And sometimes it can be that simple. That's enough. Certainly there are other times when either it happens at school or, other kind of that supervision issue is really necessary, that perhaps, professionals and teachers will need to know more for certain. But again, you can see that there's a whole kind of spectrum that we consider.
So what we want to kind of leave you with too is the positives, right? So the goal is that this child will not always have PSP, right? That they will be independent, wonderful human beings who have body autonomy, that can respect other people's bodies. So it's keeping their own bodies safe, being able to keep other people's bodies safe, being able to say how you're feeling, and not just kind of, it's really too about kind of clarifying, where can I get some of this contact? Where can I get some of these positive relationships? So who's a safe person at school? Who's a safe person at home? Who's somebody who I can get a high five or hug from? Where do I maybe not do that? And again, it's about building those healthy relationships and working. We talk a lot about mutual agreement. So that is that like those two kids being able to say, hey, I want to play this game. Do you want to play too? Right? I kind of want a hug. Is that okay? Can I have a hug? Right? It's being able to ask. It's really consent, right? But when we're talking with kids, we talk about mutual agreement, this ability to say, I want to do this, do you too? And we're going to respect if they say no, and we're going to be happy if they say yes. And that's great. So there's just so much good ways to go about doing some of this stuff.
We were actually at a conference last week, and we were talking about kind of this concept of consent is really difficult because it's actually a legal term. And in the state of Massachusetts, it just raises a lot of issues. So rather than thinking about consent, because if you ask a second grader, what does consent mean? They're not going to be able to tell you. But if you change it and you shift it to asking permission, right? It's kind of the same thing. And it's starting on that developmental journey of starting to understand consent by first understanding permission. And I think that's a really nice way to kind of think about it in a way that conceptually, a first grader, a second grader can understand is this is what I'm thinking. Do I have your permission to do that? Having that modeled for them, right? So this is a lot of the not making, little Jason hug grandma or Uncle, Joe if he doesn't want to, but really kind of starting to build those concepts of kind of my own body autonomy, my own, my own boundaries and understanding what those are. And really, again, that healthy sense of kind of not only safety, but who I am and how I keep myself safe in the world around me. So that's where I think we often land on. That's where we kind of provide this reassurance, this education. So even if we are talking with parents or caregivers whose child has exhibited this problematic sexual behavior or some problematic sexual behavior of some kind, this behavior does not define who your child is. It is something that, yes, it's serious. It needs to be addressed. These are the ways that we're going to address it right now while we are, waiting for kind of therapeutic services to get underway. But again, just really trying to take out a lot of that stigma and shame and start having conversations both with adults and then also with children and model how to do that. Because ultimately, just like with trauma, just like with, other medical conditions. We want families and caregivers to leave with that confident expectation of recovery. We are in this together. You're not in this alone. We have a plan, and this is how we're going to move forward together. So we will certainly, Jamie, send some things your way, some of those handouts. There's a really great book that just got published from the AAP. It's called You-ology, Y-O-U-ology. And actually, Diane and Mary, I bought them a copy, and we were reading through it, and it's like all those questions in puberty that like you were too embarrassed to ask and nobody really addressed with you, and it's just a fantastic little resource. So we'll send that your way as well. And then I did just want to leave you all. I know that you're, I think, more familiar. You heard from Molly last month, our trauma educator with the foster care clinic, but kind of sister to that is our child protection program clinic at UMass. It tends to actually have a lot of overlap with the same providers, but we are available 24/7. Again, for these comprehensive medical evaluations when there are concerns of abuse or neglect. We have an inpatient kind of service that we utilize when kids come to the hospital. We have an outpatient clinic. We do a lot of telephone consultation, and then we also provide some of that medical testimony when needed in court. You also know about our FACES program. Diane is a wonderful contact for that. Here's the website. Please feel free. There's a lot of great information that is uploaded, and just a lot of resources that are available to you all in the work that you do. And finally, we just wanted to say thank you. So we are a little bit over, so we're not going to do that last word cloud activity, although I would just ask kind of if anybody's willing to just share or just type in the chat. But our hope is that kind of after talking about this, maybe we've demystified it, maybe we've made it a little less sad or scary or intimidating, or like a topic that at least is potentially palatable. So if you can just kind of maybe shout out a couple of words or type in a couple of things of when we say problematic sexual behavior in children, what do you think of? And hopefully we've changed the needle on that a little bit. The last piece, this is our last QR code. This is a kind of a pilot of a new way of presenting the information that we hope was useful to you all. So if you wouldn't mind scanning this QR code, I think it's 6 questions, and it's basically, was this helpful? Did you get anything out of it? It's going to give us some actual data to go to the people who fund what we do so that we can do this for more folks. So if you don't mind filling it out, it does give us some really great information back that we will use to kind of tweak this and hopefully make it available to other people in the future.
Thank you. Yeah, I'll do that, that little post survey, and everyone else who's able to, that would be great. I'm just going to, where'd we go here? Hold on.